I invite Dr. Mahesh to come up onto this podium.
Thank you, Meena Madam, for giving me this opportunity to present here. So, even though I will show a single case video of one macular hole and one ERM, but there are other factors deciding the surgery and intraoperative management. So, I will discuss few things about that. We all know that vitreous is a gel with 98% water. And in fact, most of the vitreomacular interface diseases are due to anomalous PVD. So there is a normal PVD occurring in everyone, where there is a separation, gel contraction and liquefaction, followed by separation of the gel from the retina. When there is a mismatch, that means if the gel contracts and does not release from the retina, it causes VMT. If the gel contracts and leaves some part anomalous separation, it causes ERM, like that. So it is a mismatch of or anomalous PVD that causes the group of diseases which is classified by International Vitreomacular Traction Study Group. So this is the pathology, starting from epiretinal membrane, macular hole, VMT syndrome, and some pathologies in RD and vitreopapillary traction. So I will show one by one a few cases and then one surgical video. So this was a case of VMT. This is actually in the classification IVTS, there is a VMA, vitreomacular adhesion and vitreomacular traction. When the vitreomacular traction comes, there is a distortion of the foveal contour, resulting in symptoms of defective vision and metamorphopsia. So we operate the patient when there is both of these, the defective vision and symptoms, metamorphopsia is there. So this case is done well with postoperatively with improvement of 6, 12 and 10. It is very difficult to counsel the patient regarding the outcome of ERM and VMT because symptoms may not go completely. This is another case where there is a distortion, there is a vitreomacular traction, and this was managed by cataract surgery along with vitrectomy, but following that it became a full thickness macular hole. So these things can happen occasionally in VMT cases. And after 2 years when I saw the patient, this hole has closed spontaneously. So this we have published as a case report in IGO. So this sort of variable outcome is very common in VMT that mandates your need for communication with the patient. That is a challenge in these cases, when to select the cases in VMT, when to operate, and what can be expected from the treatment. So, but some cases like this do very well. There is a VMT, preoperative and postoperative, patient has done quite well. So operate when the patient is symptomatic, and good communication is a must. So this is the thing that I want to stress in VMT cases. Now, going to the next stage, that is macular hole. When the VMT becomes more, it can result in macular hole due to tangential and anteroposterior traction. Some of the early macular holes can close, like an acute PVD resulting in something like this. It can close. Within around 20% cases can close. So, but if it is not there, we have the standard of care, that is a surgical treatment. So if the macular hole is the treatment for macular hole is standard now across the world, that is vitrectomy, internal limiting membrane peeling with gas, and extra procedures depending on the size of the hole. There were some controversies initially whether prone positioning is needed, but this Cochrane database meta-analysis shows that prone positioning in the initial few days, a couple of 2 or 3 days or 4 or 5 days maximum, is helpful in closure of the eye. Then there are studies which showed whether ILM peeling is needed or not. But the meta-analysis in Cochrane database showed that the ILM peeling does help in the closure and better outcome. So now these are not controversies, these are standard procedures. So we analyzed around 697 eyes done over 10 years, and we had a closure of 89.2% when the minimum linear diameter, the hole size is called minimum linear diameter, base will be more, the diameter is less. So minimum linear diameter is less than 400. And above that, the success rate reduces, and above 800, it is little less. So this is our results, and and the take-home message is, if the hole size is more than 800, we need to do extra procedures like inverse ILM flap or some transplant, retinal transplant, amniotic membrane. There are a lot of methods, whichever is convenient with you. So there is no contraindication other than whether some chronic holes and some patient factors like age and comorbidities in selecting a macular hole. Otherwise, we do operate most of the macular holes, and the prone position is needed only in the first couple of days. Now, this is standard procedure. I will show the video. So initial first step is always PVD induction. In macular hole, there will not be any PVD usually, except in very rare cases. So you have to induce the PVD. We can use a chromatic vitrectomy using tricoat, and that has to be separated completely. I have mixed a few videos to show the PVD induction. You have to catch the posterior surface of the hyaloid and then pull, then only it will separate. Once it is separated, it is easy to trim the vitreous till the periphery just by rollback technique. Next step is stain the macular hole and then ILM peeling. Stain the ILM and then ILM peeling can be started. The standard treatment is pinch and peel. You have to pinch the ILM, and then peel it around the hole. So this is a standard technique. There are different methods. Loop is there, Finn's loop, lot of things are there. This is another case. Since this is not a surgical retina meeting, I am not going into the controversies and all. So this is a standard method. Peel it across with pinch and peel. There are different shark skin forceps is there. Now other methods are there. But if a person with high myopia and less stereopsis like me can peel easily, anybody can peel. You don't need anything. So this is a pinch and peel. Okay, so once it is over, you can do a fluid air exchange, and usually we put a small, SF6 or some gas like that. Usually I give SF6. So this is a standard. I am not showing the controversial other things, just a standard macular hole surgery. So after that, fluid air exchange followed by prone position. So this is a standard step. There are different studies published by us, timing and outcome of surgery so if the hole is not closing, if you do early resurgery, many of them close. Then comparative analysis, internal limiting membrane, too much peeling is not needed. A small area is around the hole is enough, so that is another study published by us. Then a lot of unnecessary ILM peeling also will cause microcystic changes and damage in the retina. Sulfur hexafluoride and C3F8 doesn't have any difference in macular hole. So these are some of the considerations that published by us in retina. Other developments I told, inverted ILM flap and stuffing, etc. But the evidence is confined to case series only. So any macular hole can be treated other than that few I told. Coming to epiretinal membrane, American Academy, the articles and recommendations, they show that the outcome is little unpredictable in epiretinal membrane, and the eye with very poor vision initially will not improve much. Eye with little better vision improves much, and the vision can improve over time up to 6 months or so. So they have studied few systematic review, and in ERM, it is extremely important to communicate with the patient. Who is a good candidate for surgery? Symptomatic patient, reasonably good vision, 2 meter, 3 meter, very chronic and gross distortion of the macula. They are not very good candidates because they will never be happy. So this was a case where there is pre-op. Okay, so this is the pre-op and intraoperative factors, standard, same thing. You can, usually in this case, PVD will be there. So using tricot, then stain with brilliant and remove the membrane. Usually this will not come that easily like a ILM. Piecemeal it will come, and then you can stop whenever you are doing damage to the retina. And this is post-op, quite okay. But in some other cases, the post-op, they will not be, I'm just finishing, they will not be very happy because the distortion of the outer retina and the vision may not be very good. Like this case, even though it would look nicely post-op, patient was very unhappy in spite of having 6/9 with anisoconia, said the size difference and all. So this is the, okay. So take home message, if the operate, if there is documented worsening and symptomatic, ideally 612 to 660 is ideal. And poor initial vision means poor final vision. Management of cataract is another topic along with the surgery. Proper communication and patient with the patient is absolutely mandatory. Thank you, madam.